Hey Cam followers, so I am very excited here tonight with the lovely Dr. Cameron Black, who is going to take you on a little introduction into regenerative medicine, what you know as stem cells, PRP. There's a lot of discussion about it. Please remember that Cam has a community group called Holly's Army. We're always got our ear out listening to what your questions are as you post them to the forum. And then what we do behind the scenes is we beaver away, go and get our contacts and try and start tackling those questions. And this has been a topic that's featured quite a lot. So I've got in touch with my mate, Cameron, to come and have a chat with you. It's going to be an introductory chat. There's no way in the world we can give you all the information that you need. But what's quite exciting is the lovely Cameron is going to be coming back probably early next year, and we're going to do a lot more. So this is an overview to start with. Please tell them about yourself, Cam.
Sure. For having me and giving this chance to kind of chat to the Cam. I'm a vet, but I have a background in on cell biology side, and specifically within so-called stem cell biology. And that's a human and animal.
Your wife
a chance to sort of apply some of the research.
2 seconds. Your Wi-Fi is a little bit bad at the moment. So let's just all breathe deep. Everybody think of the power of the internet, and let's just give 2 seconds. Let's try again. And if not, we might have to go by phone. But carry on. Try now.
Okay, just give me a up or down depending on how we're doing. Yeah. So very briefly, just the background in science. Enjoyed the stem cell biology side. Wanted to get back into seeing how we could apply some of that science translationally, so into the animals that we as veterinary professionals dedicate our lives to kind of helping out. So my current clinical role is that we are using what we know from the stem cell world in terms of musculoskeletal stem cells, and I'll touch on different populations and those sorts of things if time gives us. And how. And so a lot of the work that's going on, and exclusively my work, is in dogs, and predominantly in wound healing and inflammation, or management of inflammation. So it just so happens that canine osteoarthritis, perfect model. It lends itself so well to the work that's been done on the human side. So it means that quite literally sometimes you have animals that are being used in research and thinking, well, we learn so much from the animals, but why aren't they getting the benefit of it? So that was the kind of real driver for me, is how can we take some of the work that's going on to benefit humans, has had animals involved in that process, and actually just get that science straight into helping out our dogs. So as we all are, sort of scientists of some form or another, vet, and then trying to take the science, get it back into the clinical population, and hopefully share a bit of information when we go on it, because if we're not open, if we're not sharing, we're not learning, we're not growing. And I think if we're looking at, we've signed up to this idea that we're going to look after animals come hell or high water. So we should be much better, or best as we can, at getting the information out there and talking as professionals.
Yeah, definitely. And I think this is such a hot topic. So from my perspective, running CAM, I see people that are vulnerable. I see people that are desperately trying to make very difficult decisions. And I know from myself and my own experiences, I'm a scientist, I'm evidence-based, that's what I was taught. But when it's your dog, oh my God, it all goes out the window. And I know exactly how it feels as an owner, that you look at your dog and you just want to do the best for them. And you almost find these decisions very difficult because there's so much information. And out there's a lot of mixed information, especially about this topic. So we're going to go straight back to basics, and we're going to deal with a little bit of a myth right at the beginning by talking about the background of stem cells. And we're going to bring up this mouse that had an ear on its back.
Yes.
Let's be there. Let's do this.
So I think that didn't help when we started off back in the 70s, even some of the first work for characterization. And we came up with this typical scientist, excited as all blazers. Look, we've managed to use the mouse as basically a bioreactor. So that means that it's sort of a fancy way of growing things. And they put a construct and combined it with cells, put it in the mouse, and then the natural physiology of the mouse incubated and grew that tissue. Now we ended up with the terms everyone thinks of stem cells, and they think of a mouse with a human ear growing on the back, and it was very good to get funding going, and it certainly sparked a lot of discussion. But it was one of those things that's left stem cell biologists, or it got things started, shall we say, on two major problems. One, where is the ethics? Are these scientists just running rogue, doing whatever they want to do? And two, gosh, is it that advanced that we can literally grow organs on the back of mice? Yeah. What next? Just, whole tissue, another heart, another brain. So what I would do, if we're talking about what people are going to come across, what is their surgeon going to offer them? If we're talking about stem cells, and we'll talk about stem cells here in the UK, we're almost exclusively talking about cells that have either come from fat or cells that have come from bone marrow. And even again,
pause you there, because I don't think we finished the mouse. Just
okay.
Growing a new joint. I think that's something really important that people hear.
Yeah.
Stem cell therapy, regenerative medicine isn't saying, well, we've got a really knackered knee, so I'm going to put a bunch of stem cells in, and you're going to have a pristine little 2-year-old's knee coming out at the end of it. That's okay. Yeah. Doesn't happen.
No, it's super important. So so my experience as a scientist is that we work actually within the area of tissue engineering. So tissue engineering is a multidisciplinary approach, and you combine materials, biologicals. So by biologicals, that can be a cell, or it can be smaller parts. We could just be having proteins from the cell, things that are causing cell signaling. And the material itself can take the form of something that's biomimetic, so we are mimicking the normal biology, or it could be something that, say, we're a lot more familiar with, a metal hip or metal on plastic. Those are still a form of tissue engineering in a way, if you start to combine them with cells and fancy coatings and that kind of thing. So this idea, and I think the 3D printing revolution has also got I get very excited by it, but I do understand that it's very misleading, because you can literally print something that looks from the outside to be a new spine or a new joint. And what I would say is that this idea that we are moving towards a printed future, or a complete, designing and manufacturing a whole new joint, complete with cartilage, bone, blood vessels, and the rest of it, is not what we're talking about here at all.
So all of you guys that have been watching Netflix continuously since lockdown in March, we're not there. We're very much using it as an aid. It's not the whole deal. It's part of the picture. And when Cameron was talking about parts of a cell, I think that's really important that we stop and think about this. The stem cell doesn't come in and it just does its thing and it makes its whole new joint. It's what's within the stem cell and what it's telling other cells to do. So listen on. It's not that stem cell multiplies and turns into a joint. It's what that stem cell can tell other cells to do. Is that fair to say?
Yeah, I think, I don't, we can still be excited about what's coming in the pipeline. You can print, where you can manufacture a cartilage layer. You can grow fairly robust skin in a lab, for some sort of kind of better known examples. So there's a lot coming, But to be very clear, when you go and your vet says to you, because this is what we're talking about, your vet says to you, you've got an arthritic joint, I'm going to use stem cells. They are not meaning I'm going to use this very advanced, highly scientific joint replacement. That stuff is coming through, but what we're talking about effectively is using the biological power that's within the cells to help influence the joint.
Yeah.
So an arthritic joint is a bit of an angry cauldron. We're Halloween time, so let's go with the cauldron. And what you have in there is a whole mix between factors, so growth factors, cell types, that instead of continually renewing and keeping the joint surface and the joint as a whole in a homeostatic, so in a nice balanced, healthy way, we end up leaning towards one side where we have a bit of an angry, low-grade, bubbling, inflamed, obviously bubbling metaphorically. And
That's not crisis.
no, it's not. If it is bubbling, then definitely go to those stem cells. So what we want in that situation is we want something to try and give a little bit of direction to what is an out of control process. Now, in a classic osteoarthritic joint, we know that it's quite a low grade situation. It's probably been on the go for some time by compared to some other causes of joint surface damage, but there's still this imbalance. So I describe the use of cells to imagine. So you've got your cells. Now we need people sort of understand where have they come from. So I'm going to talk about either fat derived or bone marrow derived, and I'm talking about something that people commonly refer to as an MSC, so a mesenchymal stem cell.
Mm-hmm.
They've got other names. Now it's important to know that should be considered a specific single type of cell. So stem cell is a very broad term. When we talk about stem cells for the use in arthritis, we are usually talking about this MSC, and it can even be a population of cells within that. So when I say a population, if you can imagine, when I say stem cell, and I'm now thinking about a crowd of 10,000 socially distant people, now you could all be a stem cell. They could all be stem cells, but they can all be different types of stem cell. So when I'm interested in a subpopulation, just like you or I have distinctive features, you've blonde hair, I've got no hair, or we have glasses, no glasses. Cells have these features too. So that can either be quite literally their appearance, but also they have features in the way that they behave. So I don't know, everybody's got an annoying habit because, that's such a Cameron thing to do. But you could infer that was my character or a characteristic. So stem cells are the same. They have these both physical and the way that they behave helps us to label them and to know exactly what we're talking about. So when you read about a stem cell procedure, it really is important to say, well, what actually are they talking about? What stem cell was that? And how have they used it? So what was the disease they were trying to affect? So
if we kind of go back a little bit, the stem cells that produce heart tissue is very different to the stem cells that produce cartilage, which is very different to the stem cells that might produce the bladder lining. And people have got to remember that they start off as like the embryonic stem cell, but as we grow, they become more and more defined of what they can potentially turn into. So you wouldn't be wanting to put the wrong kind of stem cells in the joints. So we need to make sure that we're using the right ones. And that's where he's talking about these MSCs. We know that those stem cells have the ability to turn into the tissues that we want within the joint. So is that fair to say, or am I summarizing it a bit too simply?
Yeah, no, I mean, it's absolutely, it's quite a hard thing to define it's a stem cell differentiation and characterization is a huge discipline all by itself, but absolutely. So at the earliest, you have what's called a totipotent cell, where quite literally that cell, so that's within the first, depends on the species, that can be within the first few hours after you have cell fusion. You can take that, a totipotent cell, and grow a whole new organism. So everything will just grow into another Cameron or another mouse or whatever it was. And then as they differentiate, so we use this term differentiation, so that means they become more specialized. So they become more focused on the one or the three tasks that they're going to do in life. So you go from toti to pluripotent, which still means that they can form any tissue, a little bit cell biology, but any tissue within the three main germ layers.
Cool. So we've got to totipotent, we've got to pluripotent.
Yeah, and then yeah, as you say, so it's this idea of differentiation. So what can you turn it into? So the ones that we're working with, as you'd expect with bone and cartilage, that's what they're pretty good at.
I can't hear you now.
Are you so? That's a shame. I think the feedback is
right. Log off, log back on, and it'll be fine. And I'm going to entertain whilst I'm waiting for you. Okay. So guys, basically this is technology at its best. The lovely Cameron is locuming at the moment, and he has basically stepped in because I begged him. So we have to be very grateful, and this is just one of these tech issues. But basically he's going to come back and we'll carry on our talk about the difference. Oh no, he's going to come back as the person from the haunted house. No, you're okay. Good. We're back. Yes. Right. Carry on as pluripotent.
Sorry. Yeah. Sorry. It's a totally haunted house here, and we're getting a stem cell talk from the middle of the countryside. Yes. Yeah. So it was just to exactly that. So as we work down the age of a cell and its differentiation, it just means it's kind of similar to what we do at university. You know, the longer we're getting trained, the more specialized we become. And that's what happens with cells in the body as well.
That's a good analogy. I like that.
Okay. I've used these before.
I'm going to steal that one. So we've decided that we're going to explore stem cells. We've got an arthritic joint. We've tried a lot of conservative means to get there, and the owner has said, I'd like to try something a little bit more focused. What happens? What is the next step? They said, I consent. Let's try this. What happens?
Do you mind if I just have the one thing we didn't complete is the idea, and it is an important one, is that so we have these cells that we're putting in, and just go back to that kind of the bubbling cauldron or cartilage wear and tear and as osteoarthritis progresses. So just because I like to use another metaphor, but I consider that the cells go in and they're like a localized pharmacy. So only a very small part of what the cells do is actually sit down onto the damaged cartilage or into the synovium and help form or actually repair tissue that way. We do have studies that indicate a portion of the cells do that. So it's not a complete myth that they don't get involved directly in the repair of the cell, but the main is as a building block themselves. But the main mechanism of action that's sort of discussed now is this idea that they produce these factors locally. So, and they basically do one of three things in my mind. So you've got inflammation, and they're putting out that inflammation. So I think of them as a firefighter, helping to calm that situation down. They're a bit of a site foreman. So they then start to control which cells come in and which cells are sort of being removed, or debris being removed from that arthritic joint and area. And then they do have the healer effect, the one that's promoting through some growth factors, the one that's promoting cartilage turnover or new blood vessel formation, that kind of thing. Perfect. So it's like they're little like
thing you've said. They're not actually going in there. And for people that think, right, if I put 10,000 stem cells in, that's enough to coat the whole surface of that cartilage. So that's going to have the best effect, like a big picnic. You know, they're not going to be doing that.
Yeah.
And they take on different roles, and they coordinate, and they invite, and they tell things to go away, and they calm things down. It's not, you're not putting it in like some kind of super glue and expecting them to lay down a surface like lining a floor. They're in there conducting. Yeah.
Yeah, absolutely. And what's important to remember is that often you'll go into that joint, and that joint could be loading incorrectly. So it's already going to be, there may be small bone fragments in there, or it may just be a conformational issue. So there's a lot of wear and tear on that joint surface. So this is where I guess we'll go to the next question. Is always important to bear in mind, you know, what's the underlying, what are we looking at in this joint, and therefore how are we expecting stem cells or regenerative medicine to form part of the treatment?
Shall we do that before the person, our figment person, consents to stem cells? So actually that's probably a really good idea to do this bit now. So we've got Marjorie, and she has basically got a pot of money available to spend on her black lab, Sydney. Sydney's got really bad elbows, and he's already started walking with them quite out. It's quite fat as well. So she's thinking, right, I've been trying, you know, meloxicam, metacam for a while, and I've had him on JD, I've had him on the weight loss diet, and he's done a bit of hydro, but I just don't feel that we're really getting there. And she's starting to think, well, what else can I do? What else can I invest in to help my dog? What things need to be considered that could actually say this is not suitable? What sort of things do you know that people have to do before going, this is a good choice for this case?
I think you have to have, you have the animal before you, and you can see the level of discomfort or how badly impacted it is. Then you absolutely, this is still a science. So we need to have as much baseline information as possible. And so to my view, if you're considering stem cells, or you're considering another, let's say, more invasive surgical procedure, you need to know why you've elected to go ahead with that. So I'm hoping that this discussion is taking place with a professional that feels confident in the advice that they're giving. And certainly with regards to, if we are looking at elbows, stifles, these are vets that are going to have, you know, we're looking at hopefully a referral level of skill. So to my view, to consider to go ahead with putting something in the joint without, let's say, baseline information, so clinical exam, some form of X-rays and CT, and we certainly do those together, because they, one without the other, you can catch more. You sort of run the risk of maybe missing some things. And then to have a real discussion of it. Look, it really depends. It depends on the life stage, and obviously what the family feel that they're willing to want to sort of go through in terms of a surgical process and a recovery process as well. So we're then at the decision. Let's say we end up in a place where we know that, or we suspect that a surgical procedure may provide 2 years of improved comfort. Now, there are a few different options, but let's just say we're at that sort of a feeling, or we want to go through the stem cell route. I think at that point,
I think I know what I was trying to step you into. I was trying to push you into a corner. We're looking at a dog that might have had blood samples just to make sure that we've got good kidney and liver. We haven't got a hypothyroid dog. I told you he was a bit fat. We've got a dog that we have localized the pain to the joints, and it isn't actually somewhere else in that limb. So we can see dogs that have a very dramatic forelimb lameness, but it's in the neck. It's in the neck. Or we can have a dog whose forelimb lameness is really bad because actually the problem's in their back end. and they're throwing their weight forward, so the elbows just have no chance to recover. They never have a calm time. And we know that arthritis waxes and wanes. So if you've got a dog that's got bad elbows, but is also permanently having to do a handstand because its back end is more painful than its front end. So it's really, in my mind, important that the whole dog is looked at and everything is put on the table and all areas that are a concern are considered. Because what would be terrible is if you end up spending, a big pot of money on having both elbows injected, but actually the dog's still really painful in its hips. Or if you were doing both elbows, but actually had a trapped nerve in its neck, for example. So that's what Cameron was saying, is that it is really important that you go to somebody that has a multi-skill base. So they're not just focused 100% on stem cells. They can seriously, physically examine and logically plan that this is going to make a very big difference to this case. So not all dogs with elbow OA are going to be suitable for stem cells. Is that fair to say?
Absolutely. And I think my mind was jumping those steps. I certainly mean that baseline information performed at a specialist service, let's say, is exactly for that purpose. That if you've got yourself to that point where, okay, it is this problem in this joint. Now what are we going to do? Is it surgery versus maybe one of the less invasive, of which I would consider, that's where regenerative medicine comes in at that point.
And I'm just going to add a little anecdotal story just so people really know where I'm coming from. Let me tell you about a dog that I saw. This dog was about to have an elbow replacement. And this dedicated owner, really dedicated owner, had tried everything. So she'd done hydrotherapy, physiotherapy, acupuncture. She had explored all options. By chance, when I was doing my mobile service, I went to her home, and every other intervention had been done away from the home environment. So when I knocked on the door and I heard 30 kilos of dog descending the stairs at high speed, hitting a tiled floor, having to turn because there was a wall right at the end of the stairs and it had no choice but to go to stop headbutting the wall, that was a key thing that was preventing that dog ever responding to any other intervention. And it didn't matter what she did, as long as that dog was still doing that staircase 10, 15, 20 times a day, nothing was going to work. So when I talk about look at the big picture, you really do need to make sure that you're not missing something really obvious that is preventing anything working, and you feel that you're being channeled down to this is my only option. So that's just my take on it. I just want people to really get their background sorted before they go down these avenues.
I think that's, it's super important. And it's going back to how we started this feed a little bit. You hear, someone hoist the flag of stem cells, regenerative medicine, it's so exciting. Then because there is a hope thing there, or very often it's something that you feel you can jump to without perhaps having done a lot of the core work. And I think that's a really important one that and we'll get onto it. I certainly believe in the treatments that I've used that have incorporated, but it's not a substitute for a lot of the sort of just the basics. And part of the basic being a real holistic, open-minded approach to each case as it presents itself. 100%.
Good. So just before we go a little bit further, if you did have somebody come to you in practice now and say they've got a gun dog and he's 5 years old and he has had he's got elbow dysplasia bilaterally and he's had a fragmented coronoid process removed from both elbows by arthroscopy, but those elbows are inherently like unstable, and he wants to have stem cells so that his dog can carry on working because he's got good bloodlines and he really wants to prove himself. How are you going to talk to them? Because I think some people might feel that the stem cells is going to answer that dog's problem and then allow him to carry on competing. So then he's going to carry on with that dream that he's going to be this wonderful high-level gun dog. I'm being facetious, but I think it's got to be kind of said.
Yeah, it's not a completely ridiculous scenario at all. I think in those situations, we will let me approach it from a different angle. Previously, we'd really started to look at the application of regenerative medicine, or sort of this immunomodulatory effect, in conjunction with surgery, or in support of surgery, of different forms. And let's say we are looking at a surgery that's helping to address the malformation in a particular joint. And as you are describing it, something with developmental elbow disease, we have a fundamental change to how the joint loads and how it wears. We'll, when you look at the CT, when you visualize the joint surfaces, you end up with a, it's a tiny area that is carrying, as we know, usually about 60%, depending on the breed. And if that's a working dog and it's running, you've got a small area that's doing an awful lot of work. So it's really essential to talk for me to talk the owner through what that joint has to do every day in order for it just to get by. And I've been getting some physio myself, and I know that there's things that I could do less of that would probably help. I'm expecting to go to the physio once every couple of weeks, and that to undo all the times that I've been lifting weights with bad posture or ended up at the bottom of a pile of bodies in rugby or whatever it might have been. So it's the same as in there's no surgery, there's no stem cell application that is going to undo that kind of ongoing loading, wear and tear within that joint. Even though if there was something that was a suitable resurfacing, which there are a couple of options, they themselves have a shelf life. We don't know specifically, as last time I was looking at into the literature, we're starting to get a rough timeline, but I think it's important to remember that we are dealing with something that's biomechanically not favorable. So to then say, yeah, I want what you're saying is, well, why don't you ask me to just de-innovate the elbow, because we're not going to do anything to realistically rebuild the surface of that if you're going to keep loading it as you are. So for that person to go, I know it's a tongue-in-cheek example, but to say, hey, I'm going to mask the symptoms to such a point that that dog can go and work as you want it to. It's this is not ethical, and it's not possible to get to that point.
Okay, and the reason I just wanted to do that is that one of the CAM kind of teaching diagrams, we've got a pyramid of cubes, and then one of the base cubes, so we've got identify, diagnose, and then something really important is manage expectations, and that needs to be done. And I think me and Cameron have had quite a lot of talks about people's expectations might be being manipulated a little bit at the moment. And it's we felt very much it was important that we told people, it isn't going to replace the joint, and there is a strong possibility it's not going to make that dog sound to carry on competing to a really, really high level. This is a developmental disease. This is mechanically not right. Stem cells don't and act as a surveyor and a builder and quickly rebuild the joint to make it all balanced and perfect. So that's why I sound like I'm being wicked witch, but I just want people to have real expectations about what's ahead of them. So do you think we can carry on that, we're pretty happy that Mildred with her dog Sydney is a good candidate. We've dealt with her expectations. She's got a lot of good foundations in place. The house is sorted, exercise sorted, dog's weight's good, and conservative management isn't giving her what she would like. What happens? What goes on?
How do we go about it? So I think that hypothetical is those are the dogs that tend to do quite well. I think it's important for me I am standing here as someone who does hoist the sort of regen banner, and I've seen it work very well in some cases, and when used correctly, definitely for me has a therapeutic benefit. So, but it is part of that ruling out the other things, making sure the management is correct, making sure that all options have been looked at, and then we're left in, as we are now with, I forget, is it Sydney?
Sydney.
So the Sydney. The process is, for the most part, and again in the UK, let's say we're wanting to go ahead. We've had the discussion. Yes, thank you, vet. We would like to go ahead with the stem cell process. I would say so. It's important to be with make sure that this is something that they have done, and I think the experience in that is important. One of the reasons I say that is just cast our minds back to the variation of stem cell technology out there, and really, and the same applies to the blood derived products, the PRP world, that you should have, you should have a really good foundational knowledge, I think, and the guys that I've worked with do. But just as a little caveat. So the process is, for the most part, we are talking about autologous cells. So these are cells from the animal injected back into the same animal. The reasons for that is a licensing one. At the moment, that's possible for us to do without us being here in the UK, without extra certification. And so the alternative there is allogenic, when we're using cells that are perhaps from what we call a cell bank, which means that if your dog has been part of the process, they may now be contributing to cells that can go and be used among other dogs, so allogenic cells. We're also then talking about cultured or uncultured cells. And that just means, are they grown in the lab, or are they harvested with a quick turnaround and put straight back in the animal without their culture expansion? So we tend to use autologous culture expanded cells, and the data on efficacy in osteoarthritis supports that use. So what it means is that you have to get the cell sample from somewhere. So I would use a fat sample, and fat from different locations has been taken. So subcutaneous, even retropatellar, falciform fat. The reason is, we're not actually interested in the fat cell itself, but fat is a very good source of microvasculature. And these cells that we want are, within fat anyway, are perivascular. They're pericytes and derivatives. So we you do a bit of a Heston Blumenthal kind of deconstructing the fat. You get rid of the adipose cell, you get rid of the connective tissue sort of scaffold or framework. And then when we culture expand, the cells that we're looking for are very, very sticky, so that they will stick down to the plastic in the flask, and give them the right simulated environment, they'll grow, and they start to grow very quickly. So we start off with a small number of cells, and we get to anywhere from 5 to, say, 100 million going back into a joint. So the practical process, if that's the route Sydney's going, we've got to be happy that she's healthy. Happy, obviously, we've explored all the options, and we think that this is going to be a good option for her. Would come in. It is done under, let's presume it's subcut, or for the most part, that's going to be, I'm presuming, a general anesthetic. I don't know anyone who's doing it under sedation. I don't know that. And then the sample is then either processed in-house if you have a facility to do so. But there are an ever-increasing number of facilities that will process that fat for you, and the turnaround is anything from 7-8 days to 14 days plus, and patient dependent. So depending on the number of joints, the cell concentration that you want to do, and sort of linked to the disease status rather than the age of the animal, these can impact the growth rates of the cells. But let's say it's about a 2-week turnaround. Comes back.
That means for the owner, there's 2 procedures, 2 times. They're going to go in, the fat's harvest, they go home, they have to get over it, do the recovery from that surgery, which is quite minor. It's not a bad surgery.
Yeah.
And then they're coming back to the practice for another general anesthetic, or at least sedation.
Yeah, absolutely. And this is we were obviously talking offline, but one of the areas that starts to get a little ambiguous is, okay, well, you've come back for an injection. Should that be one injection? Should it be repeated? If so, how many times, and then how long between those periods? So let's say for a safe example would be a course, if you like, of 2 injections spaced 4 to 6 weeks apart. So for your stem cell treatment for Sydney, Sydney's had a general anesthetic and 2 sedations.
Yeah.
And I would say that, so the things to consider, that the GA, the fat harvest procedure is extremely minor, and it's not without risk, of course, but it's not. It really is a quick turnaround. What we have to bear in mind is that intra-articular injections in certain joints can be really quite painful. These are tender joints, and we are possibly expanding the synovium. They're arthritic. Sometimes you've got to push. There's quite a lot of new bone, scar tissue, etc., to get around or through. That in itself can be uncomfortable for the dog.
So they can go home being a little bit sore for the first few days, can't they?
Definitely, yeah.
Okay, so Sidney's had his procedure. He's had his fat harvest. He's it's been sent away. It's been cultured. It took 4 weeks. She's gone back. It got admitted again for the day. They were able to do it under sedation because he was quite compliant, old soul, and he was quite healthy, so they weren't too worried. And he had both of his elbows injected. He's come home, had some medication because he was quite sore for a few days. What kind of time scale before you start seeing the fruits of your labor? What's your experience?
So let's say we're going to have a dog that's a good responder. It can be, there's 2 different things you're going to see. There was a very nice bit of work done that demonstrated what we're calling a flush effect. So it's possible even just to inject the joint with, not saying this was from, but let's say just a biological fluid, and that itself may provide some comfort. So within a couple of sore days afterwards, and then within that sort of maybe about 10 days, 7 to 10 days, this starts to be a little bit of an improvement. Then interestingly, from most of the cases that I would see, that falls away. And we would then have a second injection, and I realize that starts to muddy things, but even without the second injection, let's say you would have a falling away of the efficacy, and then after 4 to 6 weeks, I describe it as a slow burn. So it's taking a long time to change that little inflammatory soup that's going on. Very occasionally, people would say within a week, I can't believe it. They're doing so well, so happy. More often than not, it's a gradual process. When I started using the 2 injections, that's when the results became more reliable for me. But it's still following that pattern, that it's from 6 weeks after the initial injection. So 6 to 8 weeks from the initial injection, we start to see a reliable improvement. There will have been signs before that, though.
And do you combine it? So this is not combine it with another product. That's another conversation. But there's a terrible tendency for people to think that if you influence a dog's pain state, they just do the rest themselves. So take away the pain and it does everything right. Actually, I'm just going to do a little tangent just in case my dad's listening. My dad had 2 nerves in his back, chemically cauterized yesterday. And he's like, well, that's fixed. So I'm like, no, Dad, you're not. You had to do your rehab. Now we've taken away the pain, and now you have to start getting the strength and the stamina and the flexibility back. So I think it's very fair to say to people, when you're planning it and you're pricing it, you've also got to consider there's going to be rehab time, because if you really want it to work, it's buying you a window of opportunity, isn't it? Rather than, oh, it's done. There you go. That's all you need to do. Yeah. Is that fair?
Yeah, I think you definitely, that's a good way of describing it. If you've had an animal that's maybe not been able to get into a form of rehabilitation because its mobility has been that severely impacted, you can buy yourself a bit of a window with that. But yes, once, if you gave the example of sore between the scapula because the hips were bad and they push themselves forward, or they're pushing back off their elbows, or whatever it may be, you start to give yourself time. Well, I've now the offloading behavior has changed a little bit, so I can now work on those tissues. We can moderate exercise a little bit, be that offloaded or loaded, and maybe get some weight off as well. But it's definitely a part of it. What I was always very keen on is that we made sure that there were no I'd have a standardized, as best possible, a standardized pre and post analgesia, as well as rehabilitation, so that we could be happy with what was the cell effect and what was, let's say, some of the other advised CAM management procedures.
Yeah, I think it's just this expectations thing again. It's such a problem with any service provision, be it medical service provision, veterinary, human, whatever, making sure people are aware of the plan ahead. And anybody that thinks that those elbows were injected and then they could just do what they want again is not getting the best out of it. You're not giving that dog the best opportunity. Getting a physio to help you improve range of motion, getting a better gait pattern, getting strength, stamina, etc., is really, really a really essential adjunct to doing the stem cells as well. Are you comfortable to just really quickly talk about why people would be having stem cells and PRP? We won't go into great length because I think we're going to take a lot for January, and really love all your questions, Louise. We will come to them and we'll save a lot for January. But just because a lot of people that are looking at this, they will be bombarded with that. Stem cells don't seem to come on their own. They come with something.
Yeah, sure. So again, I'll just quickly on the process. The one thing I wanted to say, because I do think it's relevant, is if you do have an animal that's responding, you have material that's there for subsequent injections.
Yeah.
So yes, they do go through that surgery, but you can store these cells. And look, there's another discussion about how long you should do it for, and how many repeat injections you can go. That's another thing. But it can end up, one surgery can end up giving you about a couple of years worth of some form of effective symptom modification.
That's a really good point to make, actually, because it is, the initial outlay can be, significant, but subsequent interventions shouldn't be so. Okay, so tell them about PRP, and then what we'll do is we'll try and hit it on the head an hour and do our 10 top tips and leave you all terribly hanging. Let's do PRP. Let's try and stop at 55 minutes. Let's answer some questions, then we'll do 10 top tips.
So we very briefly described a sort of packet releasing or drug forming effect of stem cells. Platelets are slightly different in that they themselves are not a cell, but they are these kind of like pre-packaged aid delivery vehicles. So what we do is we get the PRP. So that just simply, I apologize, I'm obviously making it a bit simple, but we've got platelet-rich plasma. That means that we have increased the concentration of platelets for a volume of plasma. It's quite a broad definition, and it's also more specific. It's meant to be 3 to 5 times the concentration, but it doesn't refer to one thing. It just refers to any product whereby we have more platelets at a particular concentration. So the rationale for that is that we, similar to the stem cell, we are delivering a sort of biological pharmacy, and that will help moderate the immune process. So the nice thing about it is that you don't have the two-stage surgical approach. You can do a blood draw. You don't require the culture facility, and there are different systems available. Some of them do require centrifuge. Some of them can be run without. Pros and cons to both. And also just to, so yeah, so that we have the PRP, the platelet systems. They've been around for a while, and there's a varying body of work on efficacy. A lot of some say do, some say don't. That, if you look into it, is same or similar to the stem cell side, because PRP really is such a broad term. What was the system you used? What was the condition you used it in? How frequently were you using it? What was your interval? All those sorts of things, as applied to stem cells. So it's become quite popular. One of the arms of the study that we looked at was stem cells in platelet poor plasma and stem cells in PRP. So we need, because when you grow the stem cells, they actually come off in a sheet. You need some way of delivering it. So it's a delivery vehicle, just in the same way as when we're drawing up vaccines, we can put it with sterile water or whatever it might be. But we found, not just us, but there's indication that the PRP and stem cells, they play well together. So they're sort of having a positive feedback. They're enhancing that factor release property, and then obviously how they can go about affecting their modification in the joint.
Yeah. So quite often, guys, you'll find, well, I'd say nearly everybody's putting the two together, aren't they? And then some people also offer the PRP on its own. So I know that some people would like to explore regenerative, but they just seriously can't afford the stem cell side of things. But they are quite taken by the idea of the PRP because it is more affordable. But just to recap what you said, there is a lot of variability out there. We still have the same rules of where is the pain, what is the disease, how bad is it, is there anything else contributing to it, have we got comorbidities, and we have to manage that person's expectations. So Marjorie with Sydney might have had her insurance run out, and she's saying, well, actually, what's another option? And that clinician might say, well, we could just use PRP. But in my understanding, those people really do need to be prepared for it to be multiple injections. Is that fair, or am I?
Yeah. No, I think that's. I think I'm now talking about something that a large number of vets have used and are familiar with, and for quite a period of time. So I'm sure that everybody would have a different sort of answer to that. My experience would be, and based on the data, is that we are looking at repeat injections. What the optimal product in the right condition, the right timing, I can give you some guidelines, but I don't think that it's known at all what that case would be. I would also just say, so yes, we do have, we're looking at it, it's cheaper, doesn't require that surgery, but probably is going to need a bit of we're going to need repeats at some sort of an interval. I think it's also important, and it's only fair to say, just so we're not falling foul of the same trap myself, there are other, we then get into the realm of other things you can inject into the joint if that's what you're looking at, trying to sort of help ease symptoms a little bit. And whether now PRP and what type of PRP is better than some of the other, and we can talk about that. But I think that's just important, to be honest. We're not at that point, clearly, to my knowledge, having an advantage of one over the other.
No, and I think it's I'm the generation where, when we're at university, as soon as somebody mentioned steroids and it wasn't related to an autoimmune disease, you're like, oh, you're a bad person, because we went through everybody used it in like the 50s and 60s, and then you come to like the generation of don't ever use steroids. And now I think we're beginning to come back to going, actually, they do have their place in different situations. And I personally don't think it's bad to use steroids in a palliative manner if we've got a dog that has got really disgustingly painful joints and we're looking at options and it's affordable to that owner. Am I wrong in saying that?
The reason I direct away from steroids is to make the rationale that what we're looking at doing is not freezing the joints, if you like. And steroids, we know, have there's the possibility of side effects. You're limited in the number of times that you can repeat, even if it is effective. Yeah, it's mega cheap, and if the dog responds, it can respond really well, definitely. But
Palliative, palliative. So I'm thinking of your
no, I get you.
Yeah. And I just only say that because I know that looking at the following that we have on Cam, we have a wide range of people that follow this page, and we have some people that are very able to afford these interventions, and this is very exciting for them. But I also am very aware that there's people that listen that go, I can't do this, and I now feel worse because I know that there's something I could do for my dog and I can't do it for my dog. Don't feel like that ever, okay? That's why CAM was created, so that you can make sure you explore all of the foundational interventions, because no matter what your financial background is, you can do stuff, and that's important to remember. And the reason I dropped the steroid bomb in there was because for some people, it is giving that dog a quality of life for a period of time. And, you know, if that makes that dog comfortable for the last part of its life, I haven't got a problem with that personally. But there is so much more to talk about this subject. We haven't talked about a minuscule amount. So what I'm going to do is I'm going to end it now. We're just going to do some questions. I'm going to flick through. There was some lovely ones. Jackie Bromwich said hello. She said that you treated shoulder OC.
Hi.
And it's been doing very well, competing in agility and working sheep. Very, very active. Somebody here. We're going to talk about that. Could I ask what you suggest to prevent future problems after having double elbow surgery? We're going to do that in 10 top tips. So there's going to be bits and bobs mentioned for there. We've answered, does cartilage regenerate? No, not specifically. It has a wider role. It can do potentially, but it's not the sole focus. We're not building ears. Is there a register for stem cell practices? How would a novice know who is good? That's a very, very good question.
Yeah, that's a good question. We don't have a sort of chartered association of stem cell biologists. I think it's a fair question, and no, I know that there are certain systems that you have to be trained to use, but I would say that doesn't necessarily mean that just means you've been trained to use it. So I would feel confident in the level of professionalism within the referral structures within the UK, within the surgeons, and I think that they are, if they're not sure, these are highly trained professionals who are going to tell you, I do or don't have experience in this area, but I do or don't have a colleague that I can recommend. So certainly with regard, but no, I don't know. Do you, if there's any sort of other way of going about it?
I know that there's attempts to try and create a register. I know that people are trying to. So there's the Veterinary Osteoarthritis Alliance, or I think they changed the name, and they're trying to really raise the bar of first opinion practice, OA care, and broad care. Not just talking about regenerative, not just talking about surgery, but good training within members of the staff, so that practice can say, we've got a higher level of training, we've got this mark on our wall that tells everybody that we've done further training, but they're not specific to regenerative. No. I was always very impressed with the referral centres that I've had dealings with. They actually don't jump to regenerative like that. They really sit back and go, what are all the options? And I think that might be something that people should just be aware of. If they're going to jump to that, just kind of go, whoa, have I got other options? Is that fair, or am I being cheeky?
No, I think that's 100% fair. I think what goes to your question about people feeling perhaps pressured to go for what is an expensive procedure. Now, I mean, I obviously believe in the field, the discipline that I work in, but it's not the 100%. It might be part of the picture for most cases, or for some cases. And so you will always have something that you can do that will have a positive impact and will be able to help your animal. You know, you never, and money may be a barrier to doing some things, but there'll be an awful lot that you can do. And 100%, if someone is saying there is only one way to go about it, or pushing you towards one thing, then question. And I would say, look, it may well be if they could turn around and say, well, actually, it's because look at these 50 cases that we've collected data on and the response, there's nothing that holds a candle to it. That's fair enough. That could be the case. But certainly within orthopedics and something as complicated and as chronic as arthritis, osteoarthritis, I can't envisage what that is.
Cool. Okay. I think that's a really good endpoint. That, as you can see, we're trying to watch your back, basically, guys. You know, just trying to give you the tools to start your own thought process. And what we're going to do is we're going to get Cam to come back in the new year, and we're going to maybe do a series where you can break down different chunks, because one of the problems with this is trying to do everything at once. So hopefully that's been helpful. And what we're going to end on is the 10 top tips, because this is really important to me, because I want to just give you a little bit of a background about me. I grew up with Labradors. We had Lancer when I was younger, and Bruno, very beloved pets, okay? Yellow Labradors. They both made it to about 15, and they both sadly went off their back legs. I didn't know what I know now. I was about 3, so don't blame me. But it's a very common situation. My parents didn't have insurance, and they were quite low income. My dad had 4 children, and he had a really busy job. At one point, he had 3 jobs. You know, they were the average family, but they still loved their dog. So 10 top tips is about people, all the things that you can do, and it's not going to be hugely heavy on the pocket line, especially with COVID. Right, so I'm going to do number 10. So number 10, I'm going to steal it from you, is weight control. It's just the absolute no-brain. Fat is not just about mechanical courage, it's also inflammatory. When you start shifting that weight, it is absolutely dramatic, the results that you can get from it. So if you think, I haven't checked whether my dog is the right weight for a while, either pop down to your vets, get a weigh in, and get them to have a feel, and be open for the commentary. Don't be defensive. Take it, so that you can actually get the truth. Because as soon as you get defensive, people start going, oh, I'm just going to try and be nice and not be so honest. You need to have honesty. And we have a lovely service on Holly's Army where the lovely Barbara and Lindsay will do a visual body condition score for you. So if you join Holly's Army, post a picture of your dog, they'll give you some pointers whether you're in the right ballpark. Number 9.
I am a big fan of age-appropriate exercise. So I think I'm having to heed my own advice in my own life. I think that we have the idea that the owner that comes in with a dog that's always been bonkers is no longer bonkers, but they still want it to be bonkers, and not being able to make that expectation. I think that's something that I kind of like to walk people through, because it just helps you think, okay, what actually, you know, you're talking about this managing expectations, but I think we probably expect our dogs to do a bit more than is healthy for them, possibly from quite an early age. And we also have to have no qualms just about letting them be in a stage of life and adjust their activity appropriately to that as well. So, you know, I think we went through the phase of the ball thrower, so the kind of relentless exercise. I go until he's, you know, he's flat on the. So yeah, so that's probably a few. There'll be a few points in this. So I'm just gonna say, yeah,
age appropriate
exercising your animal. Age appropriate exercise. We'll go with that.
I love that. Okay, so number 8 for me is me being blunt. So I used to do blunt Mondays, but I had to stop them because they got too bad. So my blunt Monday on a Thursday is, are you doing it for them or are you doing it for you? And my point on this one is things like jumping out the back of a car. Now, quite often I see people with the big 4x4s and they've got their labs and their spaniels and stuff, and they throw themselves out the back of the car. And I just think it's one of those things that's so easy to stop. When you have a dog jump out the back of a car, an average size car, 6 times their body weight goes through their joints, their forelimb joints. So you need to be aware that that is a really massive impact force that they might not need to do. So if you can say, right, I can actually train my dog to wait and I can just gently lift them out, or they can sit in another part of the car so they don't have to have that impact force. Are you doing it for them or are you doing it for you? Remember that one. Number 7.
I would go with wait and see doesn't last forever. So I think and it's kind of linked to Blunt Mondays, I think. I think we miss out on opportunities, particularly when we're looking at a lot of the things that Cam is talking about, for the I'm sure it'll get better. We'll check him in the summer. 6 months in a dog that's a couple of years old is a long time, and a lot can happen in the joint as well. So if things aren't right and you're thinking about investigation, again with the right person who'll be able to guide you on what's best and what's next, let's try intervene sooner. Intervene as however there are lots of different ways to that, but not to just wait and see indefinitely.
So number 6 for me actually comes on from that really well, and it's from Holly's Army. There seems to be a fear about reapproaching your vet if you haven't understood, you're not quite sure what's happening, you need more, you are confused, you have lost a little bit of trust, and people go, well, I can't go back, I can't ask. They didn't give me any time, they skirted me out the room really quickly. And this is where this miscommunication, that person on the other side of the table might have thought that the consult went swimmingly and they didn't realize that you were left with questions. They might have gone, that was the best consult I've ever done. They were so happy, they had a smile on their face, they didn't ask any questions because I explained it so well. Whereas you gone home and went, I don't understand anything they said. So my big tip is that I don't know bad vets. My friends are bloody lovely. And if they knew that you were going home confused, upset, they would be really upset with what they were doing. So tell them that you didn't understand. Give them an opportunity to correct it. And all you need to do is either phone up the practice and say, look, I just need extra support at this time. What can you do for me? Can I see the same vet again? Can I have a word with your nurse? Can I come in and have it explained to me? I might not even bring the dog so I can fully concentrate on what you're telling me. Can we write it down? Can you send me to the right spot so I can read more about it? Don't give up on your vet and assume that they don't care. There's probably been miscommunication. Number 5.
Wow, it's a good one. I'd add to that in that, particularly if you're seeing a lot of dogs during the day and sometimes we just don't feel as vets, we don't feel we get the time to go through things properly. So we only get to see you, to see the family members as a snapshot of their day and as our day. So if it's not being communicated, don't assume that's because, as I say, that's not because the vet doesn't want to do it. It's maybe just we didn't do it right at that time. And would always rather you got a call to say, sorry, like, hey, I didn't, not even, sorry, it's a very British thing, but I didn't catch that. Can we go through it again? Because it's not uncommon to have a recheck in 3 months' time and we've not made any progress. And that's because we weren't able to do something that was communicated. I would have felt, but obviously hasn't been. So definitely be bold. It's your doggy, your loved one, and we're here to help.
Yeah, exactly.
Okay, I would go with. No, that saves me one. You can go for it.
No, can't get out of it. Come on, can you think of one quickly?
I don't. I think one that's on my heart is if there's a possibility your dog's sore, should you not do something about it? So that comes from a place of, he's always walked like that, or it's just his funny, just his wobbly elbow, whatever it is. I know that we get into the world of lamenesses and how that links to pain and that sort of thing. Fine, but if you start walking funny one day, you're probably feeling sore, and the same applies for your dog. And there's lots that we can do. So that's a short one. But I mean, probably everybody listening here is, that's not advice they need to hear, but it's certainly advice that could be shared to the sort of the dog owning community.
Definitely agree. My one is, I'm stealing it a little bit from Louise Clark and Mike Farrell. Marginal gains. Marginal gains.
Yeah.
A lot of people go, oh, that can't really be that important. That can't be, they can't contribute that much. And it might be putting a coat on them to keep them warm, giving them a little rub down when they get in, making sure their bed's, quite comfortable, make sure they don't get cold outside, keep them moving. All of these things add up and are marginal gains to the bigger picture. And can I illustrate this really well? I had one lady who used to let her Westie going up and down the stairs. And I said to her, I don't think you should do that anymore. And she said, oh, really? Well, I was worried that people might judge me and think that I was a bit fluffy and a bit much carrying my dog up the stairs. And I was like, I don't care what other people think. Your dog needs you to carry it up the stairs and down the stairs. She's like, oh, thank you for the permission. I feel better now. Truly, that happened. She felt that she had to ask permission because she thought that people would think that she was fluffy and pandering too much. I don't believe that you can pander too much. I think all of these little things are pretty good when brought together as marginal gains to a good, better pain state. That's my one. Number 3.
Nice. I would build off that though, and I would say, we'll try to put a title to it, but we've not made these suggestions up. So it might, if it sounds, don't be put off because it sounds like it's a silly little thing that you can do. So if someone is suggesting putting down a rug, then put down, don't think, oh, really, can it be that simple? Or if we're making little suggestions about behavior, that's because they stack up. So yeah, it's don't be put off by what seems to be trivial advice. And it goes back to, I might be the one who's oh, well, you're doing stem cells. That's fun. That's exciting. That's new. I want to go that route. Surely rug on is not going to be the way forward for me, or not running downstairs. It's not going to be the way forward for me. So I would say don't be put off by what seem like very small things.
Good, I like it. Okay, my number 2, again, is more focused on the owner. So a lot of people watch Cam thinking that you're going to get these immediate aliquots of advice that's going to directly plug into your dog. And a lot of people don't look after themselves, and they end up having a hell of a lot of caregiver burden, a lot of emotional exhaustion. What I would like you to do is be able to talk to other people, because 2 things happen. You either help them because they didn't realize that their dog had a problem, but you also manage to offload yourself a little bit. It is okay to find this really hard to manage. We have lots of people coming onto Holly's Army, and you can see that they're struggling and they're almost a bit embarrassed, like it's a bit taboo that they should care so much and they worry so much about their dog. And it might be that friends or family have gone, oh, for God's sake, it's only a dog. It's not. It's really important to you, and look after yourself. Tell people, spread the love, help other people identify it early in their dogs, bring them to Holly's Army, bring them to Cam, because it's really important that we catch this disease as early as possible, and they might not know that their dog's got a problem. Number 1, it's the big one. Come on then, Cam.
You've done these more than I have.
I know.
I would say, I think it's fair to represent both sides in this last one. That we've been, I would say that be confident that when you're getting a surgical opinion as well as a lifestyle management opinion, as well as nutritional advice, all these sorts of things, don't be, how do I say this politely? We end up where we tend to be in one camp and not the other. And then we end up having these sort of divisive conversations. I think Hannah and I were talking about that a little bit, and I would say that is not the case for the most part. Your vet, your veterinary healthcare provider, and it's a team thing. All they want to do is do the best they can to help your dog out. It's the job. So try and be open-minded when you're listening to advice, and if you say, well, so and so is an anti-surgery one, so we've got to be in this camp of lifestyle management, supplementation, what have you, or vice versa. It's not the case. You have some great resources out there that can help you understand why we may suggest one thing over another, and why maybe you might get conflicting opinion between two vets who apparently work in the same discipline. That doesn't mean one's wrong, or you know, you've got to ignore one and support the other. So yeah, look at all the options and feel that you're being given all the options, and if you don't, ask that to be explained.
I think that's a very good point. Yeah, definitely. Don't sit in the dark, guys. You know, you can just go and ask for it to be explained again. You know, the vet profession, we do really care. We do really try. And there's a lot of torment in the vet world at the moment. There was a blooming awful Daily Mail article recently, which has caused a huge amount of upset to people that go to work early, work through their lunch breaks, stay late. Nearly every vet I know really does do that. So the idea that you're at home struggling with something, they wouldn't want to know that. They wouldn't want to hear that. So do approach a surgery again. Do say, I've got confusion, I've got questions. Please, can you explain it for me? Cool. Cam, you're amazing. You're amazing, as always. And you're going to come back beginning of next year. And we're hopefully going to come with a structure where we do little individual segments so that we don't try and load you with everything at once. So we will see Cam again in the new year. I'd like you all to say thank you for him giving us his time. And I will see you, I think, in a couple of weeks with the amazing Tom Brown, who I went to university with. And we're going to be talking about neurology. Why? Because it's really important at getting the right diagnosis. So hopefully see you in a couple of weeks. But otherwise, I'd like to say thank you very much to Cam, and see you again soon, guys.
See you. Thank you, everyone.